about the Milwaukee conference back in the early '80s. I forget exactly which year. The party had a conference of delegates picked by the clubs to go together to assemble in Milwaukee and talk about time of day issues and so forth. And there was a breakout group labeled healthcare. So, hey, as a budding young nurse and someone who's been in healthcare for a long time, I headed right for that particular breakout group, that workshop. And as soon as it was standing room only, as I recall, it was packed. But as the conversation began, it was very clear that there were two distinct groups of people that were gravitating toward that topic, healthcare. There were folks that had been working in the communities around healthcare reform. And I know Ron Dellums, Representative Dellums from the Bay Area, was sort of the leading spokesperson in Congress about healthcare reform. As a matter of fact, I think his bill, if it ever came out of committee and never went anywhere and was enacted, would lead us toward a national health system service like the UK is trying to hold on to. And the other group of people turned out to be a bunch of people who either worked in the healthcare industry or were staffers on unions that were trying to organize in the healthcare industry. And when they saw healthcare, they saw an organizing opportunity, and they wanted to network and do all about that. I don't think that division is as valid now. I think some of the most stalwart fighters for fundamental healthcare reform are sections of labor, including folks who work in the healthcare industry. You certainly think of SIU and its contributions to the Healthcare for America Now. We'll get into that later. Don't worry about names or anything. And of course, many of the nurses' unions, the ones that came together to form National Nurses United, of which the Massachusetts Nurses Association, on whose board I sit, is part of that. The New York State nurses that are currently independent, and others are in leading the fight around Medicare for all. So actually there's a divergence in the labor movement, and there's also a divergence, interestingly, which I see as parallel in approaches toward fundamentally reforming healthcare, and that's caused a lot of tension from time to time, and more than that. What I think, I do have some of my slides here. There's a concept I want to introduce early on and talk about, and it'll be propping up. And like I said, I'm not going to just talk about healthcare, single-payer healthcare, although that's an essential part of it. I'm not going to just talk about this, that, or the other aspect. When I talk about healthcare and what we need to do, I talk about healthcare justice. Back when we had a labor party, or an attempt to build a labor party in this country in the 90s, one of several campaigns nationally that had mounted was the fight for just health care. And of course you think, well, nothing else? You're only interested in health care? But no, what they meant was just in the sense of justice. And I've tried to refine that definition a little bit. And there are four components, I say. Folks talk about access and affordability. And as a matter of fact, over at BU, there's a whole program at the BU School of Public Health called the Access and Affordability Project. Alan Sager and Debbie Sokolar and so forth are renowned, although Debbie's not there right now. But there are other aspects. Quality and equality is what I really feel it needs to be emphasized and brought forward. We've been talking, quality, let me see how I define these terms. Access, can you get the care that you need? And I'd add in a timely manner, because care delayed is care denied. Affordability, would you get that care without going bankrupt? And that's perennial and an ongoing problem. Quality, will you survive your encounter with the healthcare system? And equality, are there special barriers you and folks like you or your community have to getting the care that you need in a timely fashion? The access part, just a little superficially here, and we'll certainly dwell on the Massachusetts plan at great length. But in 2006, what came out, the Massachusetts Healthcare Plan, sometimes called Romney Care, which is bogus. It was fully bipartisan, and it was a class plan, not just a partisan plan. Was all about stretching out the umbrella to incorporate as many people into having health care plans as possible, access to health insurance as widely spread as possible. And we'll get into why that was a backward step for some people and why it was a forward step for others next month. Affordability. Traditionally, I think the bulk of personal and family bankruptcies in this country historically have been for health reasons. And as far as we can tell right now and project, that isn't changing, either in Massachusetts or nationally. And maybe we can explore some of the reasons with all the cost shifting and everything, increased deductibles and copays and everything, why you still run the danger of your whole family going belly up if someone gets in a major accident or has a major illness. And equality. Well, there's a lot of talk about disparities in healthcare. We've been talking about disparities for a number of decades now. There's a task force at the State House for the Commonwealth of Massachusetts. A couple of our nurses on staff at the Mass Nurses Association have been representing us on that task force for a number of years, and it's sort of fallen off a little bit. MassCare had MassCare, the Massachusetts Campaign for Single Payer Health Care, is sort of the umbrella in this state for groups that are working on single payer. MassCare had some summer interns do a research project a couple of summers ago, and I'm waiting for it to officially get published, but the preliminary information coming out of that is that health outcomes in Roxbury are as bad now as they were 40 years ago. So when you, and again, it's an awful lot of work to ferret out the information. It's not obvious, and then to collate it, and then I want that information because I've been doing that quote every time I talk. I'll throw that out there. I'd really like to see the study fleshed out so I can deal with it. So access, affordability, quality, and equality. And what I say, and what I think a lot of folks that are most engaged in the health reform movement say, is that you've got to tackle them together. In 2012, the Massachusetts legislature came up with a cost containment bill, an act to shrink the amount of money that, well, clearly employers had to pay and the government had to pay toward health care. And there was, well, anyway, we'll get into that detail next month also. I should have mentioned that I feel free to interrupt me at any point. I really think all of us have had experience with the healthcare system, so all of us have valid insights. And in case you haven't figured it out by now, I'm not a policy wonk. I'm an activist. I've been in healthcare for 50 years. And even though I'm on the board of the Massachusetts Nurses Association, on the board of MassCare, the Mass Campaign for Single Payer Healthcare, and I represent MassCare, M&A, on the steering committee of the Labor Campaign for Single Payer. I don't pretend to, what I say here doesn't necessarily reflect any of those organizations. How's that for a disclaimer? I presented this material to the Labor Guild of the Archdiocese of Boston 2 years ago, and some other material last year, and what I feel free to be able to present all that material at the Center for Marxist Education without trying to not offend people who might be offended, because because we are taking a very fundamental, radical look at how things are going. As a matter of fact, I was at a meeting this morning with the representative of the Mass AFL, somebody from IBEW, the Verizon workers, and the executive director of the Labor Guild, and we were hammering out the parameters for a conference on difficulties unions are having negotiating for health care under the Affordable Care Act. We did something similar to this on May 3rd last year. It was well attended. We've learned a little bit. There's been a lot of questions that we had then have been answered, mostly in a negative fashion. And there's been a lot of stuff going on. The fourth session in the series, if you take a look at your syllabus, you will note what I consider a necessary major force for fundamental change in healthcare. I'd say probably in any sphere of activity in this country is the labor movement. Right now, it's not fit to do the job, and I think the role of the left is to help make it fit to do the job. And by labor, actually, I have a broad concept. Wherever the working class is organized in the workplace or in the community, this is the organized working class that I'm talking about, that is has the potential for driving things forward. And we'll get into a lot more of that later on. Just a little bit about, when you hear the word healthcare, what exactly do you think about, or the healthcare industry? What's in it? I don't know. Is that a leading question or not provocative enough?
Well, it's insurance companies.
Insurance companies?
That's
excellent.
Well, I think about the healthcare industry, this thing comes to mind.
Money, yeah.
Yeah.
Well, actually, finance capital is all over it these days.
Yeah.
And of course, hospitals and nursing homes and community health centers, medical practices, group practices, and so forth.
Hey Sandy, did you know that up till 1919, the AMA is for a national health service?
Yeah. I've heard that.
No, that's it.
I believe it, yeah. And they had tremendous influence. Well, historically, back in, I don't know if anybody had a chance to read the article I had posted. Oh, nobody did it.
Posted?
Yeah.
I don't read Facebook.
Oh, that's
Send
right,
it
that's
to
right.
me.
We're gonna have to find, yeah.
You know what you can do? You can send it to one of us on the steering committee for the CME, and we'll try and send that out for like the bulletins for when we announce these
Okay,
these events.
that'd be fine, because if you look at the syllabus, I have some suggested readings, and again, there's no final exam, no quizzes, so, but,
But there is a way of doing it, because you and Nick, you all send something on Facebook,
yeah,
and I get it as an email,
okay.
and then go to Facebook easily, so there.
I'll let the
must be
folks-
a simple
We
way.
can do it through email, which I think is what Sandy was.
Whatever it takes.
And that's fine. We should do it both ways. There's
Yeah.
no reason we can't.
Because any article I'm recommending has its own URL, is accessible on the internet.
Oh yeah, then.
And
there's
they're
no
also
reason-
rife with links to flesh out the discussion. So actually, if you just take that first article, which I wrote about 3 or 4 years ago, so parts of it are really dated, Healthcare USA, Social Good versus Corporate Wealth, and you followed all the links up and fleshed that all out, you pretty much have the course, so you don't have to come in. But actually, that's why I'm thinking that the discussions we have are at least as valuable as reading an article in all by yourself.
So is that this thing over here, this Healthcare USA, is that what you're talking about?
Yes. You see session 1, you go down as a little paragraph describing it, and right below it is the article.
Yeah.
And it's on my own website, Sea Change Board.
I'll find it and print it for you.
Anyway, I recommend it. I recommend anything I write. But,
Don't they all?
right. Anyway, the AMA in 1919, just taking a quick historical glance at how we got to the way we are. Historically, healthcare in this country, you had district nurses in cities often attached to what we'll call settlement houses or whatever. And you've had, roving doctors, and you've had certainly folks in the native communities who were specialists in how to help people get better. And there's a whole variety of that. And then that sort of developed in stages as we go forward. At the beginning of during World War I, and the U.S. Expeditionary Force was being recruited for, a third of the recruits were rejected for not being healthy enough. And at that point, someone was bold enough to suggest that maybe we needed a national health plan of some sort. And of course, that was duly attacked from the right for being trying to impose on the American people what the Germans were subject to under the Kaiser. Because in the 1880s, Auto Fund, Bismarck, created a social insurance network, basically a network of private but highly, highly regulated insurance companies to make sure that everybody had the financial access to healthcare as it existed at that time.
And to steal the thunder from the socialists.
Right. The German Social Democratic Labor Party was the rising power, and obviously the Junkers wanted to get ahead of that, and they did, and they were throwing it, and the reactionaries in the United States were throwing it back at you, saying, "Well, we don't want to be like those oppressed Germans," and that was the argument then. In the New Deal. Social Security Act, the National Labor Relations Act, 34, 35, 36 in that period. There was a lot of talk of extending the social insurance model or collective responsibility for everybody's well-being beyond retirement, beyond different aspects of it, beyond fairness in the workplace or the right to organize, to healthcare as well. There was talk, but it never actually got enacted. I think it was 1943, there was a bill that came that was kicking around. That didn't get far enough until the Cold War set in, and then the red baiting began in earnest. And also during that period, a lot of people got their health insurance. Well, since you couldn't get a raise during the war, the story goes, you got benefits, and the benefit, a big benefit was health insurance. And in various parts of the West Coast, Kaiser and the folks up around the Seattle area developed these prepaid insurance plans. Folks would kick in a little bit every week, and then if they got sick, they'd have a doctor available, and so forth. I think the AMA didn't like that either. It sounded too socialistic. But after the war, and the left within the trade union movement became increasingly under severe attack. So the best the labor movement came up with was the concept of healthcare as a bargaining chip, as a mandatory subject for bargaining, and it would be an incentive. If you had to get a job in a union shop. If you're in a non-union shop, organize so that you can you can have a union fighting for your access to healthcare, rather than as a social good that everybody needs, which is the way much of the rest of the capitalist world had gone, was going. In 1948, actually 46, right about the time that the UK was developing its plans for a national health service, where all the hospitals were being rebuilt after the devastation of the Second World War. The concept, the Labour Party came into power, I think, for the first time, and pushed that through. I'm sorry?
45.
Yeah, 45, and I think it took a couple of years to roll it out, but they did. And every time actually the hospitals and the facilities are owned by some organ of the state, and everybody's who works in healthcare is a civil servant. It was the basic concept. That's socialized medicine, as you hear that term kicked around. That hasn't been, like I said, except for maybe Ron Dellum's. I have to go back and look at his bill if I can find it these days. But since then, well, before we get to Medicare and Medicaid, in this country, when the UK was rolling out a national health service, we were rolling out the Hill-Burton Act, which meant big chunks of taxpayer money was going to expand community hospitals and clinics across the country. New ones were built, and the norm for most people in the country, where they would actually get the health care that they needed, was in almost like a mom and pop store. Usually their boards were made up of local real estate agents, lawyers and other business people. And they were not-for-profit. Voluntary was the term they used. I haven't seen that term used lately. And costs were relatively low and so forth. The other aspects of healthcare, of course, you had a VA system. When the U.S. Unfolded war after war after war, folks that survived that ordeal had to be taken care of in a special system. The military itself, Walter Reed or whatever, developed their own systems. Various religious organizations developed a lot of the facilities that were being used. Think of Beth Israel, Deaconess, which was a Methodist facility initially, New England Baptist Hospital, for example, where I met my wife there. I worked there for about a dozen years before I became a nurse, and yes, the chapel was a prominent center of the facility. Very religiously oriented, and St. Vincent, and to this day, Catholic outfits, mostly nuns, hold some of the largest chains of hospitals in the country, certainly out west and also parts here. And I just have to say, it was a little bit of a shock to think of it, maybe, is that the nuns in Worcester sold their St. Vincent Hospital to a group called Orenda, which was in the process, back in the late 90s, which was in the process of picking up other groups and changed its name to Tenet, because Tenet sounded very religious, and that was, so they were very legit and on the up and up. And Tenet and the RNs got organized, and we had a 49-day strike for a first contract that did not include the power of the employer to mandate overtime to fill staffing gaps. So mandatory overtime was a thing, and took a 49-day strike, but we beat them. Of course, we wouldn't have had that great story to look back on if we didn't, if the nuns hadn't sold out to one of the largest for-profit chains in the world. In the clamor has always sort of been there for a universal social insurance kind of plan. What came out of all the pushing and shoving in the 60s, the uprise, the rise primarily of the civil rights movement, and a lot of progressive thinking in the 60s, the forces came together to give us an amendment to the Social Security Act. The Social Security Act was amended to include Medicare and Medicaid. And if you want to stop and take a look, how did that hit the people of this country? If you were expected, if you had a decent job, it was expected that your employer, either independently or as a result of negotiating with the union, would provide health insurance for you. And I think the norm probably, as I recall, was, well, actually, in the mid-60s, right in that period, I was working as an orderly at the New England Baptist Hospital, and they were very paternalistic. If you get sick, we will take care of you. So I don't recall too much discussion of health insurance at that point. It was part of that paternalistic atmosphere. And of course, when we started organizing a union in '69, we weren't being very familial or loyal, and that was a problem. Tilly.
When I came to Boston and started working in packing in 1953, was on the back. We had insurance was running about $6 a week, and that paid almost all the expenses for my first pregnancy. And but the other piece is the percentage of what it costs for health insurance was much lower, let's say 1940s, 1950s, 1960s, to now. It's, what is it? It's like
17.9 is the last figure I saw quoted.
Right.
And of course, with all of the cost containment and all of the cost shifting, I'm not sure exactly where that's going, and we'll see as it plays out, as most of the Affordable Care Act has now been enacted, and we still have a couple more things down the pike. But that's.
But I'm just saying that pressure on.
So you might ask, this brings me to ask the question, gee, why is healthcare so expensive? And the obvious answer, well, the prices are too high. Then of course, why are the prices too high? And then we begin to look at, well, who are the swine at the trough? Well, we've got insurance. We've covered insurance. We've got hospitals are no longer the mom and pop store with your local bourgeoisie sort of on the board. More and more, as a matter, I just read this afternoon that Tufts was picking up Lawrence Memorial. So there's, and they were going after southern New Hampshire for a catchment area. Must be a lot of well-insured people going up in that direction. And the conglomeration, if I can invent a word, of healthcare is going. So you know, right now, you're dealing with insurance companies, you're dealing with the hospital conglomerates, which also pick up doctors' practices and everything else, pharmaceutical corporations, which, correct me if I'm wrong, but I believe spend more money on advertising and profit-taking than they do on research and development.
Oh, yeah.
And so how is that, and they advertise, you know, this isn't done in other countries, as far as I know. Advertising, here's the latest drug, you know, tell your doctor you want this. That direct advertising to potential patients is really weird. I'm going to throw another one. Oh, the people that manufacture all the things, the IV tubings and the thing, that's a big component. And these are the sectors that are at the table when you're negotiating a statewide or a national health reform, so-called. And then the other one, finance. GE does two things. It competes with Siemens in Germany to make the high-end diagnostic equipment, like PET scanners and all of that kind of stuff, and radiation therapy equipment, and all of that high-end hardware. And it also has a finance division that runs out credit cards, so you can go into debt in order to pay off all the high deductible costs you incur in your healthcare field. So, you know, they'll get you going and coming. And there's another trend that's going on, and again, I'm just being sort of macro at this point, and that's the horizontal and vertical integration of the healthcare industry. By that I mean that the hospital chains are more and more, usually under the auspices of an accountable care organization, which existed before but is being especially pushed by the Affordable Care Act. They're developing their own insurance products, they call it, not only to impose on their own members, because they're cut rate, but the service you get is cut rate, and you're locked into a very narrow network of clinicians, and you have to sever your relations unless you pay out of pocket with somebody you may have had for 20 years, and so forth. I can just, Partners is a glaring example here in Massachusetts. Dominant, especially in eastern Massachusetts, but it picked up Cooley Dickinson in Northampton recently, and it's trying to get rid of Lynn Hospital as an acute care facility, and it wants to pick up South Shore Hospital. Well, guess what? The folks in Lynn tend not to have good insurance, and the folks in South Weymouth and the towns to the south tend to be very well insured. So, and they've been stymied in terms of going down and getting, picking up South Shore Hospital because it would look too much like a monopoly, and it wouldn't look good. And they had to pass muster with the Attorney General and with the, DPH and so forth, and there's been a big pushback against that. And then I discovered a couple of days ago, actually, that they are trying to convert their acute care hospital in Lynn Union, into a psychiatric facility, which we desperately need. That's a whole other area where both the public and the private sector have really failed the people of Massachusetts. But that's one way. But in fact, it means that the people of the city of Lynn will not have an acute care facility to meet their healthcare needs. North Adams Regional Hospital, I don't know if you heard, 3 weeks ago I think it was, Tuesday afternoon the CEO called the staff into a meeting and announced in 3 days he was shutting it down. Why he isn't in jail right now, I don't know, because we have a DPH regulation that you have to give 90 days notice in the hearings and all of that of cutting back on healthcare services. And there's another law, any employer of more than 50 people has to give a 60-day notice to the workers in the community in order to make it, people can start to make adjustments in their lives. At least two laws I can think of off the book. The Attorney General went out there, talked to a judge, got an injunction to hold up the closing of the emergency room. Then went back the next day after talking to the CEO, who said, we just can't handle it. We don't have the facilities or the resources to keep it open, even though the Mass Nurses Association also sat down and with the CEO and with the folks that work there and said, yeah, we got an MD, we got a PA, we've got this nursing staff, we've got these resources, these backup people, blah blah. Yes, we can keep it going, at least the emergency room going until we hear otherwise. Well, the next day, Martha Coakley went back to the judge and they yanked that. And now the most anybody is promising is that, 45 minutes down the road, Berkshire Medical Center in Pittsfield will pick up the doctor's practices and some of the visiting nurses, programs and so forth, and will take over a standalone emergency room once they have all of the permits from the state to do that. And the community is livid. I thought we were going to have another occupation briefly. Immediately, by Tuesday evening, the community assembled and they were talking about occupying the hospital. They actually had folks in the cafeteria and so forth, and it was sort of a constant stream, especially that first week, of, well, every candidate in the state was out there to get a photo op and to make an observation. Some pithy quote that they would be remembered by. And 4 o'clock Friday afternoon, 3 days later, the police made a sweep, cleared out the cafeteria, put yellow tape all over the building, and nobody's allowed back in, and that's it. Community and its supporters and the labor movement aren't accepting that as a bit. So anyway, I got off that. I'm not really off the beaten track because I think I'm giving some examples of all of the way I put it, all of the so-called healthcare reforms, at least going back to 1991 in Massachusetts, have led us down to this path where we have the haves and the have-nots. You have a partners healthcare, which has, we believe, $1 billion in cash reserves. We have, which continues to shut down services like the Faulkner dedicated substance abuse unit, which is amazing place to talk to the nurses there. We raised a hue and cry of the community, and us organized support for the community. And as a matter of fact, I personally got to give the M&A position at the DPH hearing. I was very pleased to be involved at that level. What happened was they kept a few beds open. They did shrink it down drastically. So our kickback did keep some of that inpatient service, but most of it was gone. And it's in a time when substance abuse services and mental health services are probably more needed now than ever. For the working class, the downturn in the economy never turned up. It's only Wall Street that's making out like bandits. 7, our research so far at M&A, 7 medical centers in the state, at least that we've just determined so far, have accounts in the Cayman Islands. We have no accounting of what's there. They're no way to, they don't have to report it or anything like that. Not to say they're not paying taxes. Oh, can anybody tell me the fundamental difference between a for-profit and a not-for-profit? The not-for-profit doesn't have to pay taxes. Other than that, they are also adept at screwing people. And yep, Joe, before you go.
Yeah, thanks. I'll be here for the next one.
That's okay.
Get something for me?
We might.
Watch the instant replay.
Exactly.
Okay.
All right, carry on.
Take care.
So in terms of the fight for healthcare justice, MassCare, the Mass Campaign for Single-Payer Healthcare, we're now in our 18th year of having the best single-payer bill the state could devise, having the best economist on our side that you could think of, having the best coalition partners. I think the Mass Senior Action is certainly one of them, and M&A and a whole bunch of other folks. And a committee, and the bill, that great bill, has never come out of committee. When you go up to the State House, I venture to say that insurance company lobbyists are as thick there as farmer lobbyists are on Capitol Hill. Okay, I'll tell you this story. About 7 or 8 years ago, a delegation from MassCare had an appointment. They went in one morning and sat down with whoever happened to be the House Chair of the Joint Committee on Healthcare at the time. I forget what her name was. I'm sure I could remember. I worked the night before, so I didn't make it. I was asleep at that time. But those 7 or so people, there was at least 2 doctors, there was a nurse, and there was a bunch of other activists were in the room. And they were all shocked when that political personage told them that nothing comes out of their committee without the permission of the health insurance industry. Period. She later tried to deny that, but there were too many witnesses in the room. I was chair of MassCare at the time, so next time I sat down with Steve Tolman, who was not too senior a senator at that time, so he was still on our side in terms of being the Senate lead sponsor of the single-payer bill in the Senate. I said, Steve, is that your impression? Is it that bad? And he said that, well, it's not quite that bad. A few years before, there was a great groundswell in opposition to the managed care position of a 24-hour delivery. So in terms of labor and delivery, that was extended to 48 hours. So the drive-through deliveries was sort of pulled back a little bit. Certainly not because the insurance companies wanted it that way, but because there was such political pressure, strident political pressure, and great force delivered from below. And if we could just do that with every single diagnostic category and fight back, but I mean that's not very realistic. What we need to do is, take the whole thing on. Let's see. But I want to make sure I didn't forget any of the components. Have I slammed everybody enough? Insurance, the hospital, pharmaceutical devices, and finance.
What about 2002, the study you and I signed?
Yes. Okay. That will be explored at great length next month. But let us just say that the coalition of forces came together in '99 to put a question on the 2000 ballot. Question 5 is what you're referring to. And there were 8 organizations and one wealthy gentleman had 9 votes on the steering committee. I was lucky enough or unlucky enough to have M&A's vote on that steering committee. Phil Mamber had, this is the one time that Phil and I didn't agree. We collected the signatures and we were heading toward it was sort of an omnibus health reform measure. It would certainly finally, something that was at least 7 years in the waiting at that time, a Bill of Rights for a managed care Bill of Rights for patients and providers. There was a demand that there be a universal system of health care, and it was vague on that point, and that was sort of some single payer purists thought that was bad, whatever, that it should have said single payer. It deliberately didn't, and there would be if it were enacted, there would be a moratorium on conversion of healthcare facilities to for-profit status until such time as the universal system was in place. The theory being that the horse would have been out of the barn and the for-profits wouldn't want to come after us. First week in July of the year 2000. The legislature still hadn't made any move. They were under heavy pressure from the insurance industry and others in Massachusetts healthcare to come up with some bill that would satisfy enough of the bill so that the groups that had come together to push it through on the ballot in November of that year would not object. Finally, they came after the final round of signatures were filed. Then the next day, we got the word that the legislative leaders had come up with an idea and they were ready to deal. What they came up with was a package that included the managed care Bill of Rights that was long overdue, a promise to the single payer folks, and Phil and I were actually up in the room, and Rand Wilson from SEIU and and somebody from Healthcare for All. We're in the back room. We're actually up there with the Senate Chair of Ways and Means. Who's the senator from Fall River? He used to be head of healthcare. And the his house, and their folks all came together, and they were wheeling and dealing as to what they needed. One thought to placate the single payer folks in the room was to create a study that would show how to get to single payer. That was the mandate. How do you actually get there? Not talk about it, but give us some specific steps. I piped up and I said, well, I want that to be out in time for the 2002 elections. Early enough in 2002 so we can use that as a standard against which to judge all the candidates that year. And everybody said, fine, fine, fine. Okay. So they ran the bill through, we took it back. The coalition split right down the middle. Number of groups, including M&A, League of Women Voters, Consortium of Psychotherapy, and the Ad Hoc Committee to Defend Healthcare. And we picked up additional allies like the Springfield NAACP and Local 509, SEIU, and so forth. And we supported going forward with the ballot question because we weren't satisfied with the vagueness of the promise to give us a study around single payer. We were in the 70th percentile at Labor Day, and then the big guns came out. We didn't have a lot of money. The insurance company and their corporate friends kicked in $5 million. We had around-the-clock attack ads. One that I found is particularly annoying was a nurse manager from South Shore Hospital put on a scrubs and pretended to be a bedside nurse and said how nursing is just hates this thing, it's going to destroy blah, 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 if it went through. And of course M&A was doing whatever resources it had at the time. For a lot of internal reasons, we didn't have a lot of oomph at that time, but we, whatever we had available in our PR department and our labor program, we put into it, and came within two percentage points of winning in November. In terms of that study that Tilly referred to, we referred to it as the LECG study. LECG, those were the initials. I don't know what they stand for. Of the lead, they had three consultants who were brought in to work together to hammer out, take a look at the Massachusetts healthcare situation, and supposedly come up with a way to get to single payer. First off, that study did not come out until December of 2002, long after that election that we were trying to inform. And second, it did not really show how to get to single payer. It overpriced the cost of transitioning to single payer and underestimated the cost savings of going to a single payer system. But the best thing that it did do is point out that about 30 cents of every healthcare dollar spent in Massachusetts.
49 cents.
49 cents?
49 cents, that's why I raised it.
Well, I thought it was 39.
That was
Anyway,
one piece instead of
we won't fight over the percentage, but a huge chunk of healthcare went to overhead, profit taking, you name it,
administration.
advertising, and not to the actual delivery of care to anybody. So that was a shocker, and we tried to use that as best we could. But anyway, so anyway, thanks. We just took the thunder out of my best piece for next month. But
It is, I'll.
there's so much to talk about. We'll have plenty of it for next month.
I have it on my old computer, I mean, I had downloaded it.
Yeah, I still got it somewhere. Yeah. Anyway, I digress. So we have hospitals selling insurance to the small business community. Oh, Steward Healthcare, the big new for-profit in eastern Massachusetts. I retired from the bedside at Quincy Medical Center a couple of years ago, a little over 2 years ago. The Caritas system, the Catholic Archdiocese of Boston hospitals were picked up. They were in dire straits and heavily in debt, pensions and so forth. And this new creation came along and picked them up, but also picked up some hospitals up north, picked up Quincy Medical Center and a couple of hospitals to the south. And it wound up with where it is right now, a network of 10 acute care hospitals, 1 rehab hospital, and several doctors' practices, and they picked up, attached to Kearney Hospital in Dorchester, Labouré College as well, which they, I don't think they wanted, but it was sort of a package deal. It's Cerberus Capital Management. Cerberus on Park Avenue owns Stewart, and that's where finance comes in. We've got some very, very big players taking over and trying to find ways to suck whatever they can, whatever's left out of healthcare. When they took over, the nurses at Norwood Hospital couldn't find orange juice in their refrigerator at night. If somebody's having a diabetic reaction, the first thing you want to do is maybe quickly get something, get a packet of sugar and a glass of orange juice, and that's quicker. If you don't have that, then you start an IV and you give them an amp, at great cost of D50, you give it that way. It's a lot easier just to give them a glass of orange juice. That wasn't available, bread wasn't available. So what they did was they took some pictures of the empty refrigerator and they made some posters and they put them up all over town and all over the hospital and everything, and sort of embarrassed Stewart not to be so cheap. So there's a constant fight going on. Coming down. Anybody familiar with the term neoliberalism? I think. Okay.
I've heard it.
Okay. It's a term that's used by the labor movement worldwide to describe a changing way. It used to be a Keynesian way where you would demand that the state spend money, and the states would choose to spend money on projects to prime the economy and so forth. This sort of replaced that in many ways, and it started here in Massachusetts in 1991 with the deregulation of hospital finance, which I consider the original sin or something in many ways, setting us up for everything that followed and leading to this have and have not situation. The quickest, maybe you can give me a better definition, Doug, but what I use for a definition is this penchant for deregulation, privatization, and the worship of the marketplace as solving all your problems. And there are a lot of implications flow forth from that. That's what's going on in the UK right now. Remember we talked about the great labor-led anti-war, post-war upsurge to create the National Health Service, the pride that no one, not even Margaret Thatcher, would dare touch. The current Tory Liberal Democrat coalition government in London is, in fact, finding ways to sell off parts of it. It's estimated that the system will lose 100,000 nurses over the next 10 years. And just sort of being restructured in ways to make it more palatable to the finance capital. It's a money. It can be a moneymaker if you do it that way. In Canada, I don't know if folks who were here a few weeks ago when we showed the movie comparing U.S. healthcare and Canadian healthcare. I'll be the first to say that was a little bit idealized. On the one hand, I was shocked to see the viciousness of the fight to keep the single-payer Medicare for all system from coming into Canada. But on the other hand, all of us that are active in healthcare sort of been lulled to think that everything is hunky-dory right now. Well, I happen to know better because the Massachusetts nurses and the rest of us down here have good relations with the Canadian nurses, and they're fighting like heck to keep their system from being Americanized. When the Liberal Party government in British Columbia a few years ago tried to start doing charging upfront fees for retirees to use rehab facilities, which was out against the law, against the the Canadian Health Act. The nurses blew the whistle on that and pushed back against that. When the current Tory government in Ottawa and in the Ontario province has been really doing devastating things, the folks up there, Labour and so forth, have been really fighting back. In Alberta, sort of the Texas of the North, a lot of oil up there, and I don't know if that's why people gravitate that way or whatever, but they've been trying to move in for-profit surgery centers over the border from the United States or whatever. And again, there's been a trench warfare over there to keep that from spreading. So that we can say healthcare is a right in every country, every industrialized country except this one, which is true up to a point because it's under attack. The Tory government in Australia right now is taking steps to undermine parts of their Medicare system as well. So it's you have to have a global perspective when you're fighting around healthcare as well. You've got to help your Canadian and your British and your Australian and your Japanese and everybody else understand that you cannot let them push you toward us. What we have is not desirable, and that we are fighting to finally make healthcare a right and not a privilege.
Just a quick question about
Sure,
the
please.
Canadian system. I mean, first of all, thanks for that information, but now you can correct me if I'm wrong on this, but I
Sure.
believe it was originally introduced in one province and then spread throughout the country. And wasn't it the original plan developed either by a Canadian socialist or a member of the Communist Party, who I believe is actually very popular still in Canada?
Okay,
For the most
yeah, it
part.
was Saskatchewan,
Saskatchewan, thank you.
and it was Tommy Douglas was the
Okay.
premier. He was a preacher or something. I don't know if he also had a party card in his wallet. I never heard that, but that may well be. And it was a fight. The doctors went on strike. I guess 23 days is what the movie said. I was always told it was a month. And of course the death rate went down. I always, as a nurse, like to throw that out. And finally there was, some folks came up from Britain, and there was some negotiating going back and forth, and the strike ended, and the labor forces in Saskatchewan were supporting the scabs, with the MDs coming from the UK to fill in the scab on the. It was a very complicated situation, but anyway, and that did, and it was proved to be so popular that yes, other provinces picked it up, and the New Democratic Party, which is the Social Democratic, it's a Labour Party, or it used to be. I mean, I'm not going to get into all of the problems that it's had dealing and adjusting to a changing world, but. It was certainly something that the laborites and the labor movement felt very much vested in. And I think within that context, the communists certainly were part of that fight for that. And if you have more specific information
no,
than I have,
I was
I'd
just
like
asking. I don't know too much about it. That's why I was
Okay.
just asking.
Yeah. Okay, I'm just going to speak for a couple more minutes, and I really want more folks to talk, and thank those who have spoken up and asked questions. But when I talk about it, and again, I said I was going to introduce some concepts here that we'll make more use of in the next couple of weeks, next couple of months. Healthcare reform. This is my definition. Nobody else. I'll take credit or blame for it. Healthcare reform is the conscious and systematic elimination of profiteers. We haven't seen healthcare reform in this country yet. Matter of fact, you could say that all of the attempts at reform, as a matter, even President Obama in 2009, a few months in, at press conferences or whatever, our speaking engagements, would stop talking about describing what his current project was as healthcare reform, and started referring to it, I think probably very consciously, as health insurance reform, which is primarily what it is. Oh, okay, fine. I just throw these out, and I'm trying to be provocative and provoke some discussion. So, single payer, I usually use the term enhanced Medicare for all for life as a way to describe it. We've got this system that was, enacted in 1965 that covered most retirees. You have this Medicaid for the working poor and the very poor and the disabled. And you're supposed to have private insurance. Everybody else that has a decent job is supposed to have private insurance. And that was the worldview that sort of came out of the mid '60s. And that's breaking up. That's falling apart. And I don't want to jump ahead, but when we get to part 3, we'll be looking at length as to how specific provisions are impacting specifically the Taft-Hartley plans, the so-called Cadillac tax, which is really a Chevy tax. People have to pay so much for health care around here that they need rich benefits. And every benefit negotiated means less money in the paycheck, so it's not like you're making out like a bandit or anything. So if you eliminate the insurance companies, you've got a single payer system. That's precisely what a single payer system is, Medicare for all. you eliminate the hospital chains and take them over. You have what might be called as a VA system for all, or a National Health Service. Basically, the facilities and the personnel of those facilities are in the public sector, and so forth. And I think, how do you deal with the drug manufacturers, the device manufacturers, and so forth? Well, one way is simply to say rein them in or take them over. I have a bias toward taking them over. I believe the pharmaceutical industry in Sweden was public sector until about 40 years ago, and then it got privatized. And again, this is
It started in the 18th century.
Yeah. Public sector, though.
The King of Sweden said that all pharmacists had to work for the state. They couldn't operate their own business. That it was immoral.
Hey,
That's what my boss at Harvard.
hail to the king! You know, yeah.
One with the king.
Yeah. That's good. That's good. Yeah. And I think it's a lesson for us, for all, especially when we look at the record. When you look at individuals who have died from lack of the proper medications, either because the insurance company won't pay for it, or the pharma won't, the drug companies won't release them, or whatever. Anyway, so my penchant is to want to pull a king of Sweden, and put them in the public sector and have democratic controls. All of this, of course, we're looking at a political system where now, for the second time, the Supreme Court has loosened the bonds of money flowing to the candidates from corporations and so forth, and we have an incredibly corrupt, and that's the word I'll use. We have a corrupt political system where money talks, and if you don't have that, you're certainly in a bind. Okay, I'm going to say a word and then I'm going to shut up. I'm going to say a word about the ballot in Massachusetts, because this is April, and because we have a November 4th election day, and at the moment there are 7 ballot questions heading toward that ballot. They're probably going to be wind up with 6. 4 of them were started by labor groups. Probably familiar with the Raising Massachusetts to get the minimum wage up, and the move to get at least 5 sick days for everybody who works in Massachusetts. It's been, as far as I know, in the legislature, there's been no action whatsoever on the sick leave bill. But there's been some action, I believe, and correct me, maybe somebody knows more than is more up to date on this particular one, on the minimum wage. You know exactly what the give and take was, whether the rise was enough to warrant it. But the pushers of the bill, the coalition, SEIU is a prominent partner, the unions play a prominent part in that particular coalition, have, if by the middle of May, if the legislature hasn't to start to move, we'll go out and collect another something like 18,000 signatures, probably 20 to give you a good buffer, that they will guarantee a place on the ballot if they turn it in on the first week, the designated date, the first week in July. And again, so practically speaking, the legislature has up until that middle of the first week in July to stop that question from going to the ballot by actually fashioning, or any of the questions, by fashioning legislation or passing legislation that satisfies the demands of the folks that got all the signatures and put those questions forward. So those 2. And then there are 2 that the Mass Nurses Association took the initiative on. One is the Patient Safety Act, which is to designate a limit to the number of patients that a nurse in an acute care hospital can take care of at one time. A little bit of statistics. In 1998, 1999, the Institute of Medicine, which is a sort of a quasi-public entity created by Congress in order to advise it on matters of health policy and practice, issued a report to Err is Human. In that report, it said up to 98,000 people in the United States every year die unnecessarily in our acute care hospitals. That was sort of shocking, but it's something that those of us that have been at the bedside tend to know, whether it's falls leading to a debilitated condition, pneumonia, death, whether it's hospital-acquired infections, whether it's failure to rescue. Somebody tries to die and there's nobody around to stop them. And that was sort of a shocking number. Last year, a public interest research group, ProPublica, looked over the numbers again, and they said that at this point in history, up to 440,000 people in the United States die unnecessarily each year in our acute care hospitals. And this sort of 440,000 a year. Now this sort of parallels the overall transformation of healthcare as we've described it in Massachusetts and nationally as into an assembly line. There was a tremendous kickback in the early 90s by both the nurses and the docs and many other people and patients against the extreme forms of managed care and the cutbacks in services where people would not be allowed into the hospital until they were really sick, and then they were kicked out so quickly before they were fully recovered. That was compounded by the Balanced Budget Act of 1997, which destroyed a lot of visiting nurse associations and their ability to deliver care. In my own town of Quincy, our Quincy Visiting Nurse Association, 100 years old, went belly up at that point. So the general trend, again, Clinton and the neoliberal agenda was responsible for that. Looking at things with the wrong way. Let's see, where was I?
Right. You started talking about
The patient,
ratio.
yes.
Patient ratio.
Yeah, which of course you have testified on our behalf, thank you, Tilly. Actually on behalf of the Mass Senior Action, which has been part of our coalition for a long, long time. So we've been trying since I organized the first rally of nurses, RNs, LPNs, and student nurses on the steps of the State House in June of 1993. Remember, 1991, deregulation of hospital finance. And every month I'd get together with my cabinet of labor at M&A, folks from all over the state that were part of a union, and would hear stories. And then finally we connected the dots and said that there is a problem here. And it's not just my boss is a bastard. The problem is the system is designed for, not designed for quality care, safe care, survival necessarily. And so we came together and had that first rally. There was some internal juggling going on within M&A at the time, but what came out of it was a statewide campaign for safe care. We filed legislation, and we've been pursuing that every legislative cycle ever since we filed legislation. In 2006, the heads of the Massachusetts Hospital Association and Massachusetts Nurses Association and the House leadership sat down behind closed doors and hammered out what we thought was a compromise. Our original bill was as good as the bill that's going on the ballot in November. I'm pretty sure it is, because I don't think they're going to compromise with us now. We actually put the numbers, the ratios of nurses and patients that we found through years of experience and through reams of research actually into the bill that will be enacted when people vote on November 4th. But in 2006, in order to get it out of committee and move along, because nothing comes out of committee without the leadership's ability, you got to get the leadership on your side, and you got to get the insurance companies, I guess, on your side to move anything in healthcare. So we compromised. We changed it so that the DPH, the Department of Public Health, would do the research and take the testimony and determine what the numbers should be in the law if it passed. Went through the House, went to the Senate, the clock ran out, the session ended, and there was no action in the Senate. 2008, we have 2-year cycles, so the next time we filed it, we got it up, flew through the House, got to the Senate. We put so much pressure on the senators and on the Senate President, Terry Murphy, Murray, that we almost got it. We extracted a promise from the Senate President that she would let it come up for a vote in the Senate. And we did our homework, and we had a solid majority of the senators saying that they would vote for it if it came up. On Monday of the middle week in July of 2008, the Globe announced that the governor was having a problem funding the Massachusetts Miracle, the Chapter 58 of the Acts of 2006. He was $100 million short in his budget. And he was asking the insurance companies, the hospitals, and the public to close the gap. The CEO of the Massachusetts Hospital Association called the governor, called the Senate President, and whatever, and the deal was, we'll put in $22 million into that, toward that figure, if and only if the bill is killed. So, Senator Stan Rosenberg did the dirty work, wrote the bill on behalf of the Senate President, and sure enough, by that Thursday, we're up in the balcony counting the votes, and the bill came out, which was toothless, meant nothing. It was as bad as the American Nurses Association, which is another story, was pushing basically volunteer, let the hospitals post what their numbers are or what they say their numbers are, and then you can pick freely, as you're lying in the back of that ambulance, you can pull out your smartphone and you can review their website and figure out which hospital you want to tell the driver to take you to because they have better numbers. Totally ludicrous way to do healthcare, and of course at that point we said, kill it. We don't care. The Senate passed it. The House obviously had the version closer to what we wanted. Nothing came out of conference. The session ended, and that was that. And we hadn't made another serious attempt at on safe staffing within the legislature since then. We are making the rounds in the state right now, and we have a bill. We packed, with the help of our friends, Gardner Auditorium, the big room at the State House, and brought in solid research and basically blew the suits out of the water. So we'll be going forward in that. And the other one, I think, is especially interesting. I've been fighting with safe staffing for 100 years. I'd be so glad we can move on to something else. But this is especially interesting for those of us in healthcare. It's called the the Hospital Profit Transparency and Fairness Act. And if that's passed, it will do several things. It will require any hospital in Massachusetts that uses taxpayer money to report out all of their figures, not just some. It will require if a CEO is making more than, if a hospital CEO's total compensation package is more than 100 times that of the lowest paid worker in that facility, that extra above and beyond that 100 times, the hospital must pay back into a fund. If a hospital makes more than 8% margin, profit, we call it, they don't want to call it profit, they're not profits, that extra money, extra profit over the 8% margin is clawed back. And what it does is to go into a special account that will be used to enhance Medicaid reimbursements to the safety net hospitals, the community hospitals that are threatened, and so forth. I think it's a great idea. It's also going to expose hopefully the Cayman Islands accounts and anything else. And so we're just playing dirty. We're just, I'm sure those hospital CEOs don't want their real total compensation packages dragged out into the light of day. So we'll see what happens. To this date, to my knowledge, they have not come to us to sit down behind closed doors and try to find a compromise. And as a matter of fact, Julie was, anyway, our friends on the Joint Committee on Healthcare Finance were sharing our concerns with the legislators, with the suits from the Mass Hospital Association, asking them to meet with the nurses and the others and settle out before we all spend too much money. And yes, we're spending a lot of money. We have a lot of support from across the country as well as across the state, and yes, we are tightening our belts and so forth. So that in terms of going back to my opening remarks about healthcare justice, access, affordability, quality, and equality, I think we're moving forward. We do support single payer at the state and the federal level, and we are trying to work on certainly the quality angle and certainly many aspects of the equality angle, which includes such things as Roxbury Comprehensive Community Health Center going belly up when it's sponsoring center, Boston Medical Center is pledged to spend $200 to $300 million over the next 4 years to revamp its campus. And when the other big teaching hospitals have incredible amounts of money, that's just obscene. And the fact that whether it's drug rehab in West Roxbury, whether it's the adolescent psych unit up in Leominster, whether it's the community hospital in North Adams, or you name it, right across the state, or the pediatric unit at Wharton Hospital in Taunton. It's this neoliberal approach to healthcare, which is basically let the market rule, and as we know, in the marketplace there are winners and losers, and in healthcare I say we cannot afford any more losers. Thanks.
All right.
I did a lot more talking than I wanted to because anyway, that's good. Thank you, the folks that shared their insights.
Just 2 points I want to make. Number
Good.
one, on behalf of the Center for Marxist Education, thank you so much for coming and speaking on this very important topic.
Thank you.
Which, and that brings me to my second point. I don't really know too much about the history behind healthcare beyond, some of the milestones you bring up, like Medicare, Medicaid, and some of the background to, the Affordable Care Act and so on. But I did want to share, because I was thinking before I came today, when I learned I was going to be filming all this and everything, and I was just thinking, what's the thing that always has stuck the most with me about healthcare? And it was a story when I was about 10 years old. And I don't remember a lot of the specifics because I was a little kid, and we were going to some neighbor, someone I went to school with, who was raising money for cancer treatment. Like, they couldn't afford cancer treatment, so they had no hair, and it confused me as a 10-year-old, because like wait a minute, you're telling me they're sick, there's a cure out there, but they have to get money to get the cure, and it didn't make sense to me then. And when I became much more political, it's like, it was understood, that socialists and communists stand for, healthcare for all is a human right, and that came very much into play, when the whole Affordable Care Act came up. It's like, how can anyone think this is a good idea? Anyone, left, progressive, or popular force. And it was just like, that was something that always had stuck with me, since I didn't know a lot of this history, and that was like, since before I became political, just that story of someone who just could not afford basic treatment and had to raise money. And
Well,
it was
remember
sickening.
the fundamental contradiction of capitalism.
Yeah.
The, public welfare versus the private expropriation of the produce of society and so forth, and apply that to healthcare.
Right.
It's the same thing. Healthcare is a socially necessary good. Everybody needs it to one degree or another at one point or another, but it's become more and more and more the private aggrandizement. Individuals or corporations are getting their profit needs, or their perceived profit needs, supersedes the rights of people to have quality health care. And it's also, the whole trend also is to finance capital taking over the 1%. It's not just...
That's the new piece to me, you brought out in this.
Yeah. Well, fire. What's the big unproductive 1% thing? Fire. You've got finance, insurance, and real estate. These are the things. I remember back in the 60s when we first became active in terms of fighting around, I think we were fighting Peter Ben Brigham Hospital and the Baptist and the Back of the Hill organizing committee on Mission Hill and Roxbury. The big issue, these big institutions were so evil because they were expanding out and sucking up real estate, and people needed housing, and we organized a group called the Roxbury Tenants of Housing. Maya was very instrumental in all of that as well. So, and then, and again, Victor Seidel from New York City, the folks were writing or analyzing healthcare system in terms of the real estate market. Fascinating. Now we also have, certainly the role of insurance and the deregulation of hospital finance in Massachusetts. And every state is different, or is experiencing the unfolding of this healthcare crisis in slightly different ways. Professional licensure, hospital licensure, insurance regulations, a lot of these are done state by state. New York State is just getting to the point where maybe we were in 1992 or 1993. A couple of years ago, there was a report that came out that said that, we have far too many hospitals, and so they've been shutting them down. The community, SEIU 1199 and the New York State Nurses Association and a lot of other folks have been fighting in Brooklyn to keep open. The Long Island College Hospital, called Litch, part of owned by the state system, and Governor Cuomo is the villain in this story, and the others that are trying to shut it down because we've got too many hospitals, we don't need it. Although this particular community feels like it needs its hospital, and Interfaith is another community hospital that's on the chopping block. So there's been tremendous struggle there. Like I say, struggle. When I look at healthcare, what I see is a roiling cauldron of class warfare, class struggle. You don't know it, you don't see it. You got fights going on here. Everywhere there are fights going on. Every time the 1% tries to turn the screws, folks are reacting. Now we just have to find ways for us all to react and find an agenda that we're all moving forward. Single payer is part of that, no doubt about it. We have next time I'll try to bring it. I've been putting out since January, a monthly newsletter around health justice for Boston. It started at Mel King, some folks may remember, still around. I'm sorry?
He spoke Saturday.
That's right. Yeah, I was at another function, unfortunately. Anyway, I won't get into that. Anyway, he looked at the advisory board. We had a meeting of the advisory board of Mass Care early in 2007. And he looked around the room, and he was the only person of color in the room. And he made the observation in his very measured, solemn tone that unless we have the folks that are most sharply impacted by the crisis in healthcare participating and leading in that fight, we're not going to get anywhere. He's absolutely right. It took me a couple of years to get Mass Care to sort of begin to go that way, and we evolved with the Three Cities campaign. We said that we really have to build a base of support for fundamental healthcare reform in Springfield and Worcester and Boston. Some very, very good folks, retired professors from Amherst, went down to Springfield and tried to organize. Yes?
I just wanted to ask, do you have any statistics on the number of nurses that lost their jobs when the hospitals merged with when they bought the smaller health
Sure.
organizations?
Yeah, I can certainly dig that up. I don't have it off the top. I know there are 530 people lost their jobs when they closed down North Adams, and at least 100 of them were nurses. But again, all of the folks certainly are necessary. We now have fewer nurses in Massachusetts per capita than almost any other state. They really, really got reinvented. I'll try to dig out the figures. And of course, I remember one of these hearings on our safe staffing bill. Must have been about 8-9 years ago. The nurse executives got up and said, "We have just as many nurses in our hospitals today as we did then." And we looked at each other and we delusioned. Well, one thing they might mean is that there are more nurses in management now than are actually at the bedside taking care of patients. One way in which they cut back on our ends was to expand the role of the nurse's aide. And at the same time that they sort of wrote down the list, they broke down the responsibilities of the registered nurse into a laundry list of tasks, and then gave tasks to as many other people as possible, so that one nurse then had fewer tasks, but would be responsible for and liable for twice as many patients, with the hands-on care being given more by folks. So there was basically, it was a de-skilling process of nursing was going on, and that was a big issue. And I think it actually started at Boston, well, the old University Hospital, which is now part of Boston Medical Center, and at Quincy City Hospital is where the consultants came in and started their first experiments. And then in 1989, we had our first huge layoff. Layoffs were in healthcare were almost non-existent. It was mostly, you know, a small department would get merged, you know, little things here and there. But starting in, certainly at Quincy in 1989, massive layoffs of folks in hospitals. So whenever anybody raises the issue, and it's a legitimate issue, about all of the people that work in insurance offices and doctors' offices processing insurance forms that would lose their jobs with the importation or the development of a single-payer system, because we won't need insurance anymore, and billing would be much more direct and simple. I say I sympathize with you. Any single-payer bill worth its salt will have massive, will have adequate provision for transition to new jobs, training, or whatever. But I also say, and I may be a little almost vicious in this, nobody gave a damn when all of those who were actually taking care of patients were shown the door. RNs, LPNs actually were the first to go back in 85, 86 from the bedside. And it's, and patients, the bottom line is, though, that the patients are deprived of the kind of care and the kind of experienced care and the kind of educated care that they need. Quincy Medical Center is what it's called now. It used to be Quincy City Hospital. I worked there for many years. Almost all of my RN experience was in that hospital. But after, when I officially retired, the negotiating committee asked me to stay on. We were in the middle of negotiations with Stewart Healthcare, and they appreciated the history that I brought to the table, and they asked me to stay on. So sure, I'm always up for a good fight. You know, I can recall that. But it's been, it took us 23 months to get a contract, first time after Stewart took us over.
It's Sandy.
Yeah.
The Boston movie. Are you in touch with Elmer Freeman?
He's on a mailing list of mine, but I don't know him personally.
Oh, I do.
You know him personally,
oh,
yeah.
very
Yeah.
much so. And you.
He gets the acquaintance put him on our.
So you should give him a call.
Sure.
Or I'll get, and then you use my name.
Okay.
You know, but
I got his stuff somewhere. We send him a newsletter and all that.
Yeah, because they're really good people.
I think I've actually met him at you know, a meeting or a conference or something on the place. I know we shook hands and chatted for a few minutes years ago. Nothing recent, but we need
Yeah,
to.
he was my next door neighbor.
Good, excellent.
Book Frankie O'Day, second president.
Oh, very nice. Yeah,
But no, he's really good.
I was going to ask you Wales Avenue, but not. I was going to ask you Wales Avenue. But
No.
we go back a ways. Yeah. Yeah. Okay. Anybody have any last-minute observations? I just want to say next week we're going to get down and dirty. I was just kidding. Yeah, my story next month will be a couple of minutes shorter because of I tell you, bringing up the the year 2000 question 5 and in that particular story. But there's a how did we get to this point? Remember when Michael Moore filmed the movie Sicko, and it was released to the public in June of 2007. The first public showing was in Sacramento, and we had nurses from all over the country flew out at the invitation of the California nurses. We hadn't yet formed, that took until December of 2009, we hadn't yet formed the National Nurses United. But, so we were there, and me and my wife and a nurse from Boston Medical Center lives in Weymouth. We're the Massachusetts delegation, and Karen was our president actually at the time, and they needed somebody to get up and speak to represent the nurses of Massachusetts, and she shoved me forward because she didn't want to speak. we had we were at the state capitol in Sacramento, and before we had our rally out there and a podium and all that, and then go down and see the movie, we went inside. Michael Moore was going to have a press conference, and we wanted to see if we could sneak in. There were two nurses from Alberta who were on the way back from their biennial convention up in Newfoundland. Two nurses from Alberta, and the three of us from Massachusetts, and there were a few of the California nurses around. And we were sort of in the room, and the state police or the Capitol Police, whoever came by and asked us to move along. We said, "Oh, sure, yeah." All the California nurses got up and left. So tough, you know. And of course, we said, "Oh, yeah." We sort of milled around a little bit. We're waiting for Michael Moore to come in, you know, to see what he had to say. Finally, we decided after 5 minutes that we probably should get our Canadian colleagues out of there, because they wouldn't be able to come back into their country if they started getting a police record here. But that was fun. So anyway, we went down to the stage that was set up on the lawn, and Michael Moore did his verbal presentation, and after he'd given his press conference. And folks from each of the states and provinces that were there got 3 minutes to say what they were doing for single payer or moving the agenda forward. I happened to be last in line. A couple of docs from Physicians for a National Health Program spoke so long. Quentin Young and David Himmelstein took up so much time talking about what healthcare was like when they were residents, that all the string of nurses from all these states and provinces were under extreme time pressure all of a sudden. And when it got down to me, I had 1 minute, and I was the last speaker on the podium. And as I was going up, somebody from California said, "You got to tell them, how did Massachusetts get to be, the bluest state and get to have this Republican health plan foisted? You know, what the hell happened?" And so I did. I sort of fudged it around, but what I said and how we did get, in my opinion, at least how we got to that, I'm going to save for next month. Thanks. I am going to, folks, haven't seen these yet. I did promise I would share these wherever I went. We will be collecting more signatures. Like I said, probably.
I've got Berwick's, the papers here. Anyone who wants to sign.
Okay, anybody wants to sign for?
Well, John signed. And
I signed at the Mass Care event.
Oh, very good.